So today we have a treat of a trio of presenters. And so we're excited to hear some of the hot topics in med ed and hear about some of the national work that they've done. And hopefully it'll be an inspirational and energizing time for all of us to kind of get all of our ideas down for how we want to pursue some innovation scholarly work in our future endeavors. So just a couple of intros for our speakers. So Dr. Mutter is an assistant professor of medicine here in the Division of Hospital Medicine at the University of Colorado School of Medicine. In addition to her inpatient practice here at the University of Colorado, she works closely with first-year med students as a clinical skills coach, is the assistant course director for the gastroenterology course for first-year students, and the site director for the internal medicine acting internship. With her presenting today is also Dr. Amy Weinstein, who is an assistant professor of medicine at Harvard Medical School and a practicing general internist at Beth Israel Deaconess Medical Center in Boston. She currently serves as the director of Harvard Medical School student programs for the Beth Israel Deaconess Medical Center Department of Medicine and Beth Israel Deaconess Medical Center Core 1 Medicine as clerkship director. In addition, Dr. Weinstein serves as the vice chair of the clerkship directors of Internal Medicine Survey and Scholarship Committee. And then we also have with us, so there's a little bit of an AME theme going on today, but we also have Amy Kwan, who is a primary care physician and assistant professor of medicine in the Division of General Internal Medicine at Oregon Health and Sciences University. She served as the director of the Internal Medicine Clerkship since 2021 and serves on regional and national committees for the Society of General Internal Medicine and the Alliance for Academic Internal Medicine. So without further ado, I'll hand it over to our trio of presenters. As always, I'll monitor the chat and kind of collect some of the themes and questions for the Q&A session at the end. And then just also know that Kara will throw in probably about midway and towards the end a session evaluation for your feedback for our session today and any other suggestions you have for other topics or speakers you'd like to see at this Ed Grand Rounds series. So with no further ado, Dr. Mutter and friends, I'll hand it over to you.
Thank you so much. I'm just going to share my screen. That was a long and awesome introduction. I appreciate it. Just going to pull up my slides here. And there we go. All right, perfect. So as Amy mentioned, the three of us and two other folks that you can see listed here, Dr. Mullick and Dr. Alexis McBee, are all, just to provide you with a little bit of context, we are all members of this survey and scholarship committee through the clerkship directors of internal medicine as part of this Alliance for Academic Internal Medicine AIM. And each year at one of our national conferences, a group of us are sort of tasked with performing the annual systematic review of the medical education literature, and specifically more under UME, since all of us have roles within UME in the clerkship space. And so we actually presented this already, actually a little bit longer one at our national meeting. And for this particular session, since it's a bit of a broader audience and lots of different medical educators in different fields and different spaces, we tried to select a sample of studies that are pretty broadly applicable to educators at various levels. So hopefully this is enjoyable for all of you. As Amy said, maybe spark some curiosity for future research. And then just wanted to note that we are all clinician educators, but not necessarily content experts in any of these areas, although we are very, very happy to answer any and all questions that you have on these important topics. And just to make sure that we all get through the content, we'd love to either hear questions in chat throughout, feel free to put them in the chat, but we'll answer them at the tail end in addition to the Q&A that's already scheduled. All right. So to start, this is kind of a busy slide, but it just gives you a sense of how we started this systematic review. So this is kind of our literature search strategy. So lots of terms sort of related to curriculum, med ed, various journal articles that you can see here on the bottom. And so we performed this large PubMed search for all published papers relevant to our topic and throughout all of 2024. And then we did exclude just a few different types of articles like commentaries, editorials, perspectives, etc. And with this initial strategy, actually, there were over 1,700 articles that we initially identified in PubMed. And then after doing a title and abstract review and then fully assessing the articles, we ultimately presented 21 articles at our national meeting. Today, we won't be presenting all 21. We're presenting 9 of them for brevity, probably for time's sake, but also just to highlight some of the ones that, as I mentioned earlier, we thought were just the most applicable to learners across all the spectrum and across various fields. And we had an amazing librarian here actually at the university, Catherine Downton. So if anyone needs her assistance for anything, she was exceptional in helping us through this process. And then we used Covidence software. And with this, also just wanted to share a little bit about the rubric that we use to try to make this process more systematic. And these are the 4 components you can see here on the left. So how rigorous the study design was with the components noted here, how applicable it was to our particular audience, which again was the clerkship directors of internal medicine nationally, whether we thought it was important and innovative and novel. And so with that, we use this to compile our final group of papers to present. And then these are some of the themes that we identified that you'll hear about today. So curriculum, assessment, AI, wellness, artificial intelligence, AI, wellness and bias and equity. And then as you can see, there's just like lots and lots of overlap among these different topics. So with that, I'm going to pass that off to Dr. Weinstein, who's going to start us off with talking about student assessment.
Thanks, Marina, and thank you all for the opportunity to join you all today. I'm going to share my screen. Does that look good? Thumbs up?
Yes. We can see your presenter view, Amy. I don't know.
Oh, okay, sorry, let me, it shouldn't do that. Second. That's what I was worried about. Can you see it now? Hold on, from current slide. How's that? Are you still seeing the presenter view?
It's actually now just the PowerPoint view.
Perfect. Okay. So here we go. So the first section today we're going to talk about is the section on student assessment.
Amy, it's a little bit cut off. Do you want me to go back to, yeah, do you want me to go back to mine?
Sure.
Okay, here, I'll just pop that on and you just let me know when you want me to advance it. I just want to make sure the audience can see. Okay.
Okay.
Does that look okay?
Yes.
Great.
Okay, thank you. Okay, this looks great. So next slide. So the first question we wanted to ask the group to really kind of start thinking a little bit about this section on student assessment is when you are asked to assess professionalism, what qualities do you assess? And we just ask that you put some ideas in the chat so that we can think about this. Go through a few of the articles and then see like how everyone did compared to some of the latest literature. So I'd love to see if you folks enter some comments in the chat about what qualities do you assess when you assess professionalism? All right, and I'll while I'm talking, feel free to enter some ideas. So integrity, great, ethics. Communication, excellent. Follow through, being on time, timeliness, great. So we'll keep entering those and we'll talk a little bit more about professionalism. So this article that we chose to present is entitled Student Professionalism in the Clerkships. It's by Cochran et al. And was in Clinical Teacher in 2024. So on the next slide, these authors asked, how can we better define, teach, and assess student professionalism? And as background, we all know that professionalism can be challenging to define and assess. And even as I'm looking here in the chat, you can see that everybody has a slightly different idea of what they're going to say or how they're going to assess professionalism. So our narratives tend to be vague. They tend to be a little bit all over the place. And interestingly, the current literature primarily focuses on breaches in professionalism rather than on milestones. So students who struggle also, we know, are much more likely to struggle later when it comes to going from the clerkship to the sub-I to residency and even to clinical practice. So it is really important for us to think about this early on in learners training. Next slide. So for this study, this is a qualitative study that was done at a single 7-year BS-MD program, a relatively new medical school in Harlem. These authors very comprehensively looked at 753 formative and summative core clerkship final narratives for all of the students' clerkships in their entire core clinical year for 99 students. The team developed a code and they took the professionalism narratives, which were then categorized, and then they identified themes. So on the next slide, you can see here are the results. For the demographics, this particular medical school, about 2/3 women and 1/3 men, which may or may not represent some other medical schools and even your medical school. Like typically, I would say that the mix is typically more like 55-45. They have a large percentage of URIM students with 31% Black or African American, 12% Latinx. And of those 753 narratives, 23% contained language on professionalism. And this was actually quite good. This was second only to medical knowledge that was represented 36% of the time. So here on the right, you can see that the professionalism narratives were grouped into the level of detail, with the level being low, medium, or high. And the authors then looked at the high quality professionalism narratives to try to really define what it is that we're talking about when we talk about professionalism. So on the next slide, they found that there were 7 main themes, and you can also see the sub-themes that they identified here. And these included time management, as some of you said in the chat, following through on expectations, eagerness to engage, work ethic and efficiency, effective communication, going above and beyond, and situational awareness. And on the next slide, what they did was they created a hierarchy of professional behavior. So you can see in this pyramid that the skills that were more basic were at the bottom. So for the first 3, the expectation is that students should really be at this level at the clerkship entry. Then the next 3 after that, 4, 5, and 6. This should be achieved by the end of the clerkships, and that situational awareness was felt to be a much more advanced skill for the sub-I and then beyond into residency. So on the next slide, the limitations and take-home points of this particular study are that although this was a new school and this may not be fully representative of other medical school populations with greater than 40% being URIM and 2/3 women, they really did a nice job of defining a professionalism framework, which can define positive professionalism behaviors, which can in turn then support learning and assessment. And so on the student side, this supports self-directed learning and emphasizes growth mindset, since the students really have a more clear understanding of what it means to be professional and what they need to do to achieve professionalism. On the faculty side, this really supports faculty development and helps describe and evaluate professionalism. And then overall, for both sides, this supports much more specific, formative, and summative feedback. So next slide. So we have another article that also looks at professionalism. This one is called Moving Beyond the Dichotomous Assessment of Professionalism in the Internal Medicine Clerkship, Results of a National Survey of Clerkship Directors by Montgomery et al. In Academic Medicine. Again, everything was in 2024. So how do IM clerkships think about and assess professionalism? So really little is known about this. And so in 2021, through a Clerkship Directors of Internal Medicine national survey, the authors examined how IM clerkship directors view professionalism. 103 clerkship directors responded to the survey, which is really a quite robust response at 75%. And 94% of the clerkships reported that they formally evaluate professionalism. 62% of those clerkships also factor professionalism into the clerkship grades. And down here at the bottom, you can see that the authors categorize the type of professionalism into different types of lapses. And this is really based on some other articles from the medical literature. So lapses in involvement, like students showing up on time, students getting their assignments turned in, introspection. So this is really like lapses in student kind of self-awareness, communication, and then integrity. And you can see here that involvement was really the highest, with like close to 80% reporting that involvement issues were very common. followed by introspection at close to 60%, communication at 39%. And then luckily integrity, which obviously would be the biggest breach, somewhere around 23%, but still a good amount. So barriers to assessing professionalism. This was asked of the clerkship directors, and as you can imagine, many barriers were noted, but the most common barriers that clerkship directors reported were the lack of direct observation, so really relying on reports from others. Only learning about this feedback at the end of a rotation, so very hard to really address it when you don't really know it at the moment. The subjectivity of the report is also a challenge. So, just because this one person thought that the student was late, do I really consider that to be the same concern? And then also a fear of retribution by the learner. And interestingly, close to 50% of the clerkship directors were really afraid of what what would happen and what the learner would kind of come back and do based on this reporting. So next slide. So the take-home points for this study is that there are a variety of professionalism issues, which really demonstrate the complexity of the assessment of professionalism. Most clerkships lack standard assessment and documentation practices, and many barriers to identifying and addressing professionalism exist. Similar to what the first article noted, the current state really does focus on lapses and remediation. And this article suggests that, like the first article, that we should move towards a developmental model that nurtures a growth mindset and growth of professionalism. So next slide. So we're now going to present a few of the articles that were investigated so nicely by our colleague Tina Mullick at the University of Tennessee on bias and equity in medicine. So another question for all of you in the chat. So our next question is, what challenges and opportunities do you see in addressing bias and promoting equity within medical education? And I know this is a tough one, but we'll give you all a minute or so to just come up with a few ideas. We'd love to see what you have in mind. So lack of diversity and program leadership, that's a good one. Great, keep them coming. So current political climate, varied education of educators. It's challenging not knowing the intentionality, funding and support in this climate, institutions becoming reluctant to engage in the climate. Yes, certainly a big concern. All right, so next slide. So this article is titled Bias Reporting in the Clinical Learning Environment, a National Survey of Internal Medicine Clerkship Directors. And this was in academic medicine in 2024. So on the next slide, we know that bias exists in the internal medicine clerkship learning environment, and it's really unclear how often bias is identified, how bias is addressed at institutions across the country, and what are the best practices for mitigation. So on the next slide, this is another CDIM national survey. 152 medical schools received the survey, and there was a 73% response rate. And of those clerkship directors that were surveyed, 78% reported at least one bias event per year, with a median of 3 events per year. And you can see here that the clerkship directors were allowed to answer more than one category, but 57% of the time they noted the events to be microaggressions, 64% of the time race and ethnicity, and 55% of the time related to gender. Less commonly observed events were gender identity, sexual orientation, an accent, a disability, a religion, age, or culture. And on the next slide. So then the clerkship directors were asked where they heard about these bias events from, like how they were actually, what types of events were happening. And the number one source of clerkship bias events was actually individual interactions with attending physicians. This was about 70% of the time, followed by individual interactions with residents, 55% of the time. And then interestingly, individual interactions with a patient or family member, 36% of the time. Luckily, many of these other events were much less common, including bias in clerkship grading policy and bias in opportunities given to different groups of students. So we're doing a little bit better there. As far as the mechanisms of reporting for bias, there were many different types of mechanisms, as you can see here, not one single standard, and a lot of both formal and informal ways in which bias events were reported. So for example, like a formal way of bias events being reported, and probably most commonly, is the end of clerkship evaluation, reported about 56% of the time. But then also a little bit more informally is an email to the clerkship director, also at 56% of the time, or an informal conversation with the student, 46% of the time. An evaluation of an individual faculty member by a student may have triggered this as well. And you can see here like many other ways in which students were reporting bias events. So bias reports seem to be at least at the same level, if not increasing, compared to the data that these authors looked at from years past. And the question is why? And I think, we all know there's a heightened awareness of systemic racism especially when this paper was done in 2021. Especially in 2021, right after, kind of in the earlier stages of the pandemic, an increase in burnout potentially that could lead to unprofessional behavior. Clerkship directors were much more aware of the learning climate now than they have been in the past, so perhaps students are reporting more. And yet we also know that bias is still underreported and there's no clear best practice yet. So I think this paper also kind of describes that there's a lot more work to be done. And with that, I am going to turn it over to Marina. You're muted.
Oh, thank you, thank you. Oops. Ooh. Okay, am I unmuted now? Sorry about that. I had a hard time visualizing that top part to unmute myself. All right, let me pop back onto the PowerPoint there. Okay, so the paper that we're going to talk about, two of the three, in this bias and equity, and here is racial and ethnic bias in letters of recommendation in academic medicine, a systematic review by Deshpande et al. In academic medicine. And so to provide a little bit of background here, we know that letters of recommendation are extremely important and are key components for residency, fellowship, and beyond. And a prior systematic review that the authors noted did find actually a significant gender bias in letters of recommendation, where males were found to have more words surrounding leadership qualities, and women were found to have more words surrounding communal language and concern for welfare of others. And there's a thought that perhaps standardized letters of recommendation may be more objective with less bias, although this area is a little bit less studied. And then thirdly, that there are still quite a lot of disparities, as we're talking about here with these papers and in general, within those underrepresented in medicine. For example, they often, fewer students are elected to AOA and fewer students receive honors. And so with that background in mind, the authors of this systematic review looked at all published studies from the inception of databases, essentially through July 2023. And they looked at any papers that reviewed letters of recommendation or standardized letters of recommendation that pertain to either racial, ethnic, or underrepresented in medicine bias, and looked at physicians and trainees in medicine. They actually had pretty robust data here. So 23 studies, over 19,000 applicants, and over 41,000 letters of recommendation that were included here. And the majority of them were for residency applications, and then the remainder here were for fellowship, and actually none were for jobs or beyond. And so the first aspect of the letters of recommendation that the authors wanted to take a look at were linguistics, or the words that were used in these letters of recommendation. And they noted that there were fewer agentic terms in URIM, so terms such as skill, strong, lead, confidence, active, work ethic, although there were other studies that did not note these differences. They also noted more communal terms in those in Black and Latinx applicants, like agreeable, warm, considerate. Again, some studies did not note a difference. They also noted more grindstone terms, such as dedicated, hardworking, organized. Again, heterogeneity here, with some noting a difference and some not. More standout terms in white applicants, like exceptional, best, outstanding. More emotive terms for anger in URIM, and more doubt raisers, so language that hedges or veiled criticism or faint praise. In addition to linguistics, the authors wanted to take a look at topic differences or the content in some of these letters of recommendation, and they noted that there was frequently less discussion of surgical skills in those from URM backgrounds. And then finally, they wanted to take a look at, well, did standardized letters of recommendation change? How does that compare to the more traditional narrative letter of recommendation? And URM applicants did have fewer linguistic differences in the standardized letter format as compared to the traditional letter format, although there were some studies here in this review that showed that URM applicants had lower global assessment scores and rating in some studies. So less of a difference that they noted, but did not fully go away. And so talk about this a little bit more. This systematic review does seem to suggest that there is some bias against URM in letters of recommendation. Although the authors did note that there's quite a bit of heterogeneity in the studies, especially in how they defined some groups of applicants, and that there were overall small numbers of URM applicants within the bigger studies that they pulled from this systematic review, so just kind of small numbers. Interestingly, it was skewed towards procedural specialties, so cardiology, orthopedic surgery, some of those, and that it's not clear if that represents a publication bias or whether there's some signal here. And there were many studies that did not demonstrate a difference at all, so just a lot of heterogeneity in the effect. And those studies that did show an effect, it's not clear to what extent the effect size is. And that also standardized letters of recommendation may reduce, but not fully eliminate racial and ethnic bias. And of course, our goal is ideally for no bias at all. Or perhaps, as Dr. Kwan is going to talk about, maybe there are some tools for us to help recognize bias in letters of recommendation, which may be challenging for us to recognize our own intrinsic biases. And maybe this is where AI has a role in at least the recognition piece. And then the third paper we're going to be talking about in this bias and equity theme is We Need a Seismic Shift, Disabled Student Perspectives on Disability Inclusion in U.S. Medical Education by Jane et al., also in academic medicine. And so talk about a little bit of background here. We know that students with disabilities continue to encounter inequities in medical education, such as possibly poor training conditions, lots of structural, cultural, perhaps climate-associated barriers, and that there still exists a disability-related stigma. In addition, many students don't disclose their disability for various reasons that actually they'll talk about in this paper, or even request accommodations. And if the needs of students who require access are not met, there's a higher risk of poor outcomes within this population, such as longer time to graduation, lower board scores, higher burnout rates, increased rates of depression, etc. And that there often still exists a culture of ableism within medical education. So to talk a little bit about the methods, the authors in this paper reviewed a set of free text responses in the AAMC Year 2 questionnaire that is distributed to all medical students at the end of their second year in 2 cohorts, 2019 and 2020. This was part of a bigger AAMC survey, and for the purposes of this particular paper, the authors performed a thematic analysis of narrative responses to the below question here. So use the space below if you would like to share anything about your experiences regarding medical school and disability. And so this particular question was only shown if the students had self-disclosed a disability earlier in the survey. And so 9% of students actually did and received this prompt. So to go into the results, they had 674 free text narratives, and of the 9% of students who self-reported a disability, 27% of those did provide a narrative response to this question. Although the caveat here is that in order to protect the anonymity of the students, they de-identified the data, so it was not linked to any other demographics that might have been captured earlier in the survey, and so the authors couldn't necessarily provide demographic data or what specific disabilities the student self-identified with or what accommodations they did or did not have, for example. So in the results, the first thing that the authors wanted to do is to map the system. So what kinds of systems did these students sort of encounter and experience, and how did that shape their perception of disability inclusion? And the 4 subtopics here that I'll be talking about in the next few slides are the structure of the program, various processes, people, and culture. And as you can tell, all of these are sort of interwoven and interrelated. So thinking through the program structure, what we mean here is how exactly are the curricula taught? What does the workload look like? What does the schedule look like? What is the physical and perhaps electronic environment that the students are working in here? And the students really noted that how the structure was set up really significantly influenced a lot of their experiences and whether or not they sought accommodations. The students noted that if there were barriers to requesting specific accommodations, that kind of sent out the message that all learners need to learn in the same exact prescribed ways. And if there were inaccessible conditions, that really added to the students' labor because they had to spend time sending emails, talking to other people, requesting accommodations, providing necessary documentation or paperwork, etc. So it just created a lot of extra time and labor on the part of the student. Although there were actually several students who noted some favorable elements here. So not all of this was necessarily on the more challenging spectrum. So schools that had some more built-in flexibility, for example, in timing of taking tests, that was extremely helpful. And then in the second component of processes, this is how the students attempted to broker accessibility and how were they supported in their well-being. And a lot of this related to the accommodations that the students requested. They noted that there should be a need for clear, efficient, and transparent processes for how to request the accommodations that the student needed. And specifically, they use this word to include not othering processes, or they didn't want to be made to feel like they were an other. And that processes that were burdensome, again, just required a lot of time and advocacy that took away from other expectations that they had within medical school. Thirdly, in terms of people, this is how what the relationships were with other faculty, administrators, other students. And the students here noted that quality and attitudes really mattered, and they could really make or break it. So they could make conditions much easier or foster seamless engagement if they had an excellent administrator that was able to easily accommodate the accommodations. That was great, but there are some staff that might have made this more challenging if they weren't sure of, exactly what to do, or the processes were more challenging. And they also perceived a lack of power. So if they were caught in sort of a void or an email chain and didn't know what to do, they just often felt very powerless if they weren't able to obtain the necessary accommodations. And then students also still perceived a culture of ableism. And then here are some kind of interesting quotes. There's lots of different quotes in this paper that I didn't have time to share here, but I'm going to share a few of them because they were really interesting. So one of them commenting on the program structure: "I consistently feel like I'm a fish being judged by my ability to fly. Needless to say, it is extremely frustrating, exhausting, and makes me constantly question my worth as a student and whether I belong here." Secondly, it was incredibly difficult to request accommodation originally when my school was requesting that I go through the global university resources, talking through the process here. And then I faced a lot of discrimination and harassment from administrators and faculty regarding my psychological disabilities. And then after the authors mapped sort of the system, they then wanted to talk about, well, how did these students navigate the system in which they worked? And there were a variety of different administrative, social, and internal mechanisms that you can see here on the bottom. So if you follow this bottom chain where it says supports needed, these are examples of various administrative mechanisms. So starting at the bottom, some students asked for access and received access, though other students often labored or felt like they were caught in a void where they just were sending emails or attempting to contact this person or that person and just never quite got the answer or the accommodations that they requested. In terms of social mechanisms, many students often kept their disability a secret. They still felt a lot of shame and stigma surrounding this. And some students at some schools created their own communities and said that was a very important component of navigating the system. And then finally, in internal mechanisms, some students felt that they could do it on their own, that perhaps they either didn't need the accommodations because they had been living with their disability for a long time and knew how to accommodate, or they felt that that was just simply too burdensome and they did not want to labor as much as was necessary. And some students mentioned that they saw other resources like medical management or mental health services or things like that. Some representative quotes here are, I've had to do a lot of self-advocating for accommodations, and I frequently feel as if I were a nuisance. I know the types of accommodations offered to students with ADHD, and I don't feel these accommodations would benefit me enough to make up for the stigma of identifying myself as a person with ADHD. And then finally, I haven't really found that I needed any form of accommodation during school. I've struggled with my diagnosis since I was 9 years old and have found very decent coping strategies as well as medication that works for me. So again, some representative quotes of how different students navigated the system. And so to sort of conclude this here, the authors noted that actually this was an analysis of the largest known data set of disabled medical student perspectives. And specifically here, they were able to capture responses from students who did not necessarily request accommodations, which was a limitation of prior literature. And as you can see, their experiences were highly divergent. Some students had maybe more challenging circumstances, and other students were able to request and be granted the accommodations that they needed. And that the initial hurdle was really just the structure that was in place that impacted the processes and the people that were necessary to interact with and request accommodations. And many students had overwhelmingly positive experiences here. However, all of the students pretty much universally noted that they felt that their disability was something to be managed throughout their time in medical school and that it remained highly stigmatized. Within the limitations of this study, unfortunately, we did not have any demographic data to contextualize the experience, so it's unclear kind of what the disabilities were and what accommodations may have been requested, for example. And these, as a reminder, are all students at the end of their second year of training, have not yet entered clinical training, which, as we know, provides a different set of challenges. And then these are just two representative quotes that I want to end this paper with that were really interesting that Dr. Mullick included here. Medicine is still made by and for abled people and on the basis of an abled physician. And then I'm hoping that people with power in medicine, you, will actually recognize the need for a seismic shift, hence the paper title, and how we approach disabilities. And then with that, I'm going to pivot into the wellness and curriculum theme. There's one paper I'm going to present here. There are a few others that actually are included at the tail end of this presentation for those that are interested, but we just felt like we're maybe a little bit less broadly applicable. So the paper here is When You're in It, It Feels Like It's Everything, Medical Students' Experience of Failure and Remediation in the US and Netherlands by Mills et al. In Academic Medicine. And so the goal here, the authors wanted to specifically explore medical students' emotional or affective experiences of failure or remediation in their medical training. And so they conducted virtual interviews with 9 current medical students in the US and 5 in the Netherlands in 2022. And the only inclusion criteria they noted was that the student had not met expectations on at least one medical school assignment, which was pretty broad. So they could have failed an exam, failed a clerkship, anything else in between. And they specifically chose students within these 2 cohorts, as within the US, as we know, we have a typical 4-year curriculum, whereas in the Netherlands, they have a time variable curriculum that's set to be completed within 6 years, but the authors in the paper noted that most students actually complete the curriculum in 6.5 years, so it's actually quite common for students to complete it later than is what would be typical. And for their analysis, they did a codebook thematic analysis of interview transcripts. And so just a little bit of background on the demographics of the students. They didn't gather full demographic data, but they did note that of the participants at the US schools, all of them had failed an exam, whereas at the Dutch schools, the majority of them had actually failed a clerkship. And at the time that they were interviewing the students, most of them had already successfully completed the remediation process. And so we're talking about it afterwards. All of the students felt that whatever experience it was that they were talking about, so their failure and or remediation experience was a significant event in their education. And that shame was very pervasive and was a very strong, at least an initial negative emotion. And there's a lot of other emotions such as self-doubt, resentment, blame, especially initially, some external facing factors. And a lot of these students assumed that they were unique in having failed and didn't realize perhaps that other students may have also failed the same exam or the other people were in their boat. So for example, one student noted, I now realize how little that first year really matters in the grand scheme of things, but when you're in it, it feels like it's everything. And that with time and additional perspective, a lot of the negative emotions softened, but often did not fully resolve. So for example, one student noted, before this, if I didn't do something right, it's annoying, but it works fine. And when I do something like that now, I think, oh, you see, here we go again. I still haven't learned. I'm beating myself up more. And that a lot of students noted worry and stress surrounding how this particular experience might impact their career, but there was a differential between the two countries. So very few students that were interviewed from the Netherlands actually noted a lot of worry and stress. And actually, some of them even had a positive emotion here where they felt like this extra time gave them some more knowledge that was necessary to enter the residency. Which might make sense given that there's more of a time variable education system. It's much more common to delay graduation. But this was definitely a common theme in those students from the US. And so to conclude, negative emotions are very common and they did improve, but interestingly, really don't fully go away for a lot of these students over time and might have a significant impact on professional identity formation. And perhaps we need to have a greater need to normalize failure. The students in the study noted that something that was extremely helpful for them was to build a community of same-sex or same experience peers or role models. And that's what really helped some of the negative emotions soften, is to realize they're not alone. There are other people that have gone through this also, to sort of have role models that are later on in their education that have succeeded despite perhaps an initial failure. And some interesting limitations here are that there wasn't a US medical student who had failed a clerkship or clinical experience that elected to participate here, which might suggest that perhaps those emotions are even more strong, or they might not have felt comfortable sharing in this environment. They're all current students, so we don't know how many students who might have failed, dropped out of medical school entirely. The extent of the remediation, I don't think anyone in this study had remediated a whole year or longer. And there's a potential bias perhaps for students that feel comfortable sharing their experiences, even potentially like years out from the initial event. So with that, I'm going to pass it on to Dr. Kwan, who's going to share a little bit about artificial intelligence.
Awesome. Thanks, Marina. And I'm just going to share here. Hold on 1 second. Hopefully, can you guys all see the slides? Okay, perfect. All right, so I have this last section on artificial intelligence, or AI. And obviously there's a wealth of information and literature on this topic, but we try to really kind of boil it down to 3 that were particularly relevant. But that being said, I honestly can't see the chat, so this is more for kind of like the group to sort of brainstorm together. But probably at Colorado, there have been some ways that generative AI has been used already at your institution, particularly in the teaching realm. And so, just thinking about, are there areas where you're particularly excited about AI in your own work, or where you found it really useful? Or conversely, are there worries or fears that you have about using it? So feel free to pop in the chat and sort of, I feel like these tend to be kind of binary in terms of how people take AI in their work. So I think it's always interesting to swap ideas.
Slides.
Oh, sorry, what's that?
I can't see your slides.
Oh, you cannot?
Mm-mm.
Oh, okay, hold on.
You can see them.
I can see them.
You can?
Mhm.
Oh, okay,
Mhm.
never mind. Ignore me then. Maybe there's
Okay,
something.
thank you.
Okay, just wanted to make sure everyone else could see. Yeah.
So some just basic terms and concepts to know. This first one is called natural language processing, which is essentially an umbrella term that refers to the ability of machines to understand, interpret, and generate human language. There are a lot of things that fall under this category, but the ones that we're really going to focus on are the large language models, or LLMs, like ChatGPT and Claude, which are basically a subtype of natural language processing model that specializes in understanding and generating human-like text. They're often referred to as generative AI, and that's really what these papers are looking into. So with that, we'll talk about our first paper written by Sridhar and colleagues and published in JGIM actually earlier this year. And it is on comparing scoring consistency of LLMs with faculty for formative assessments. So the problem really boils down to doing narrative written feedback is obviously a huge time investment for faculty. So the question was really, can LLMs help support this task in a meaningful way? So the study design was a single institution, multi-site, retrospective cross-sectional study at the University of Illinois College of Medicine, and the LLM that was used was ChatGPT 3.5. Basically, what the authors did was they went into a prior academic year where they looked at written assignments that had already been submitted by students and actually graded by faculty. And they selected about 100 of these assignments, these graded assignments, for review. And basically the criteria for selection was that they could not be perfect. There had to be some sort of deficiency as defined as one of these criterion in this grading rubric. And the assignments were picked so that there was distribution across these 6 different subcategories of the grading rubric. The de-identified assignments were then given to ChatGPT along with a grading prompt. And then finally, the faculty score was compared with ChatGPT's score. So the bottom line is that statistically speaking, as you can see by the p-values highlighted on the right, there was no significant difference between faculty and ChatGPT assessments, which at first seems a little bit depressing maybe, but if you look at the percent exact agreement between ChatGPT and faculty scores, you can actually see there's quite a bit of spread with pretty good concordance of about 80% for fairly straightforward questions like, does this answer all PICO components, to a much lower concordance for things like things that require more application, context, and critical appraisal. So this is actually a representative example. I'm not going to read the whole thing, but you can see that generally ChatGPT, and this again is paired for the same student feedback. ChatGPT was quite positive, while faculty had a lot more granular detail, and the feedback was a lot more constructive in terms of giving the student something actionable to work on. So the take-home point here is really LLMs are not really ready, especially for high stakes situations, to really generate narrative text that really requires a lot of critical synthesis. But it's, this area is developing so quickly that it's worth kind of revisiting this question, and it will be worth revisiting this question soon. Regardless, I think it's important to realize that whatever output that ChatGPT comes up with and LLMs come up with, they really do need a lot of careful editing and interpretation before they're sort of passed along. Okay, with that, I'm going to switch to our next paper by Shalong and colleagues, published in Medical Teacher, and this is about enhancing self-directed learning with a custom GPT. So the problem here is that self-directed learning is obviously a critical skill for physicians to develop. So the question was really, can LLMs help medical trainees develop this skill? And this was actually a randomized controlled trial. It was a single center open label trial held at a teaching hospital in China. And the participants were 100 undergraduate and postgraduate students studying clinical medicine. So roughly the equivalent of medical student and resident here. And they basically had to have access to ChatGPT, but could not have used it for significant learning assistance over the prior 2 months. Basically, of the randomized individuals, they were split evenly into a control and intervention group. The control group had access to ChatGPT only, whereas the intervention group also had access to what's called a custom GPT. That's basically a custom build of GPT specifically designed for this project, and it was specifically designed to help students develop these skills. Plus a utilization course on, how to do appropriate prompt engineering and how to most effectively harness the technology. This was followed by a 12-week course, which had integrated weekly required problem-based learning assignments, and then a 2-week washout period when those assignments were not required. And then at multiple times throughout the study, there were 2 measures of critical thinking that were measured, a more subjective version called the self-directed learning scale, and then a more objective measure called the Cornell critical thinking test. So you can see here at baseline, there was no significant difference between the 2 groups, but that as the study progressed, specifically at the 12-week mark, you did start seeing differences in both of these scores, and that interestingly, that these were durable differences that, that stayed even after the study was discontinued. So the take-home point here is that LLMs possibly can help medical trainees develop self-directed learning, with the caveat that it's clear that access to LLMs is actually not enough. That the intervention group, whether it was the custom GPT that was specifically designed, whether it was the appropriate training, or whether it was the required practice and utilization, it's unclear which of these or whether all of these contributed, but again, access is not the end all be all. And one interesting limitation that the authors brought up was that, access to custom GPTs is relatively restricted to those who have premiums paid subscriptions to LLMs. And so that brings up some equity issues potentially. Okay, the last paper we're going to talk about was by Turner and colleagues, written in Academic Medicine last year, and it was about making use of natural language processing tools to better understand medical students' self-assessment. And the question that this was really answering at its base was, can these tools help identify useful themes from huge amounts of free text narratives? Again, this was a single center cross-sectional study at the University of Cincinnati College of Medicine, and the data set that was used was huge. It was over 2,000 reflective self-assessments submitted by students, and the tool that was used was something called TopX, which is proprietary and developed by VCU. So the idea here was that after a standardized clinical encounter, students would respond to these 2 prompts. And then those free text narratives would undergo multiple layers of analysis by TopX, and then finally undergo a final sort of analysis, both individually and by consensus with the full group of authors. And then with the assistance of a natural language processing expert, they extracted themes for both of these prompts. So you can see here that in response to both of these prompts, there were multiple themes that were identified, and also the frequency with which those themes was identified was also generated. So the authors postulated a couple of interesting potential applications. You can imagine that if you have a course or a rotation that you're getting feedback for, that this is kind of a more objective way to sort of see, what's really working well with this course, or conversely, what is an area that could use some improvement. And if you think about it more broadly, you can use this tool a little bit both on an individual level and at a broader group level as well. So the take-home point here is that these natural language processing tools certainly can help identify themes from large amounts of text, but as is pretty clear from this study, it did require a bit of technical assistance with those with expertise, which may not be possible kind of across all institutions. So that's definitely a limitation. So in terms of a final take-home point for our entire presentation, I know we went over a lot of content, but first, I think it's important to remember that a professionalism framework can help both trainees and faculty define and target specific behaviors and encourage a developmental approach to professionalism rather than a binary, you are professional or not approach. The second point is that bias, especially in the realms of race, gender, and disability, does persist in the clinical environments and beyond. It's a little bit unclear exactly how, we can best address this in terms of standard practices, but it may be addressed by standardized approaches, for example, to letters of recommendation. Thirdly, failure in remediation does have durable negative emotional impacts among U.S. medical trainees. And then finally, generative AI has many potential useful and exciting applications in many different domains in MedEd, but it does require careful editing and interpretation of output and proper training on appropriate usage in order to get the most bang for your buck, if you will. So with that, I just want to thank you all for your time and attention, put in a final plug for the Alliance for Academic Internal Medicine. And I know we're kind of short on time, but we'll take any questions. Thank you.
Perfect. Thank you so much. That was a whirlwind of all sorts of exciting hot topics and themes in MedEd. So congrats to you for kind of organizing and giving us kind of a swift overview. I feel like I just had hours of reading the latest MedEd articles just offered to me. So thanks for making it easy. I know we do just have a couple of minutes left. Any questions from the audience? We've talked about hot themes around professionalism and bias and disability and assessment, topics that hit all of us in our clinical and administrative roles. But any topics or any questions for the panel here? And maybe I'll kick off one, just knowing that this was kind of a national society kind of driven work or committee led. What are the next steps from kind of y'all's end? Have y'all identified research priorities or anything like that?
I'll just jump in and say, this is a talk that is near and dear to our hearts that we do every year for this national meeting. We used to have a venue where we were able to publish the data, but unfortunately we don't at this point. It does help to inform some of our national survey work that we do, and anyone who's involved in UME is actually able to submit survey sections to our national survey. The call comes out every fall, and we look for content that is really current and relevant. And so you saw several of these sections, and this data actually came from some of those surveys. But it comes from folks everyone who's on this call who has an interesting question and is thinking about what is the current sort of literature and what is missing from that. So I'm not sure if that answers your question, but a lot more to be done, I would say.
Perfect. And it sounds like you do this every year. So every spring we potentially could get a little refresh.
Mm-hmm.
Yep. Fantastic. And we did have a question about posting these slides. And yes, we put a recording of the presentation itself as well as the PowerPoint slides on the Ed Grand Rounds archive website. So you'll see that within the next week or so. And without further ado, it's 1 o'clock Mountain. So we'll let everyone go. Thanks everyone for your participation and see you next month. And thank you again to our presenters.